Yeah.
No, no, I appreciate the introduction. I know a lot of you guys here, so it's nice to come here and talk about something that I deal with a lot. Um, it's there's two of us in CIE here at Tampa. It's me and Dr. Khan, who I'm sure you guys also work with. Him and I are kind of partners in crime when it comes to this stuff. So you'll see a lot of us in these charts. If you have any questions, feel free to. This is very informal. Feel free to ask. And what I wanted to talk about was pancreatitis and the complications thereof. And we'll go through all the different flavors and issues and special circumstances that you guys may see, and try to cover this in this talk. So I'm not going to talk about chronic pancreatitis. It's not as fun of a topic because there's not a lot we can do for it. And it's a whole separate topic. So I'm really just going to focus really just on acute pancreatitis. So the goals of this, we're going to define what that is. I know that sounds simple and rudimentary, but it's actually very important. I can't tell you how many times when I was the MAR, when I was in residency program, the ER would call me to admit a patient. I got a patient with pancreatitis. Just sure, okay, fine. They just want to just sign the patient out. It's your problem. And you go there and see them, and their lipase is like 62, and it's like, okay, well, hold on, there's something else here. So I think definitions is important. You guys should always take it, with what you're told with a grain of salt and figure it out yourself. I'm going to talk about, it's important, coming up with etiology is, and obviously that helps ties into triage and ultimately into management. And there's things that you can do long before a gastroenterologist is called. That's, I would argue, is more important than anything in the hospital. So with that said, I'm just going to describe the case. We'll just keep this case in the back of your mind. So 78-year-old woman, history of kind of like the triad: diabetes, blood pressure, heart disease. Comes to the hospital with 3 days of nausea, vomiting, epigastric pain radiating to her back. No alcohol. She's got stones, but no bile duct dilation on ultrasound. Some elevated transaminases, lipase 3000, and everything else looks fine. So ER calls you to admit pancreatitis. This is our CAT scan here, and we'll go through some of the CAT scan findings here and stuff that you can see. But I'm a big film junkie. That's just me. I like looking at all my films just because I think a lot of stuff gets missed. And it helps. I think we're better than a radiologist because we have all the clinical history. A radiologist has no history at all. They just have maybe a one word, one sentence, an ICD-9 code. So for us, we really have a lot more information. So I know what I'm looking at when I'm looking at a CT scan. So I think what's important here, you can see the pancreas enhances. So you see here's the spleen. This is the liver. This is contrast in the aorta. That's the celiac trunk. That's the splenic artery. But you can see how this is the same, basically, density as the spleen and liver. And that's a good idea that lets you know that, hey, this pancreas looks good. I don't see any necrotizing pancreatitis. There's a little bit of a haziness around the borders here. You can start to see some haziness around the perinephric fat on the right side. And some fluid kind of here in the groove between the duodenum and the pancreatic head. Here's the bile duct here, right here. So again, how do we define this? So it's really, you need 2 or 3. So it's pretty simple. I know it sounds really basic, but I think this gets lost a lot of times. So it's abdominal pain, nausea, and vomiting, with either elevated enzymes 3 times the upper limit of normal and/or radiographic findings of pancreatitis. So it's simple, but just keep that in the back of your mind. Lipase is more specific than amylase. Keep in mind with hypertriglyceridemia-induced pancreatitis, the amylase can be normal. It's just a kind of a caveat. In terms of imaging, again, there's different types of pancreatitis, and we'll go through this. We just went through this is kind of like what you see, the radiologists say acute interstitial pancreatitis, kind of like the scan we just showed, same thing. Pancreas enhances, you have some inflammation on the pancreas, maybe some fluid in the pancreas here. It's textbook garden variety, acute uncomplicated pancreatitis. And then you start getting these things. So again, this is kind of the same kind of picture, but over here on this side, you start to see a lot more inflammation, a lot more fluid. Again, pancreas still enhances. Then you get one of these where you have some pancreas here, some pancreas here. Can you guys see yeah, you guys can see the mouse. Okay, good. And then
want to make it red?
Yeah, I don't
Because
see.
we have a
Oh, do you? Oh,
better
okay.
dot.
Okay.
And then it's easier to follow.
Oh,
Is it?
wow. Man, I need one of these. Tax system needs one of these.
It's kind of
Yeah.
medicine,
Yeah. So here's the tail. You can see a little tail that enhances, and you got a hole in the middle right here. So this if I saw this CAT scan on it, especially on a mission, I'd be worried about this patient. But so this is kind of what you see in like that's what they mean. There's no enhancement here. So this is probably necrotizing pancreatitis just because of the lack of enhancement. So, in terms of timing, going back here, so if you have this CT scan on hospital day 0 in the ER, doesn't mean the patient won't go on to develop organ failure, necrotizing pancreatitis. So you really need like 2 to 3 days where you're really going to get a good sense of how the pancreas looks. So it's nice if they have if they have this kind of pancreas when they come in, but it doesn't mean that they won't have a complex, complicated path, which you see in patients with organ failure and pancreatitis. So just keep that in mind. Timing of imaging is important. So again, back to this patient. So what do you think? When you look at this, this set, what do you think maybe the cause of this lady's pancreatitis? I think it's pretty straightforward. But like, what do you think? Think it's a scorpion bite? No.
Or the low alcohol.
Yeah. So, so I mean, so it's probably stones. How come the bile duct's not dilated on the ultrasound? So you still think it's stones? Hmm? May have passed a stone. I'll tell you the more likely scenario that the tech that did the measure the whatever they thought that was the bile duct was not the bile duct. I see this all the time. How do I know that? There's a CAT scan an hour later and the bile duct's 12 millimeters. It's like, well, it's dilated. There's no way it was 3 millimeters an hour ago. So you do see that a lot. So I think with ultrasound, there's a lot of I think depends on the tech sometimes. The radiologist is just reading still images or not. They're actually doing the ultrasound. So but yeah, so my assessment would be this 78-year-old woman with looks like uncomplicated, biliary pancreatitis, and vital signs are stable. There's no cholangitis, and that would be my assessment of, when I was admitting this patient. So the first step that I think is important is try to figure out the cause, because that is important in terms of, is there anything else that needs to be done, especially with treatment, but figuring out the cause. So how do we do that? AI is trying to replace us all, but it won't take away. You got to take a history. So that means talking to the patient. Again, this is why we're better than radiologists and in other specialties too, because we actually sit down and talk to patients. So social history, you want to talk to them, ask them specifically about alcohol, tobacco. Tobacco is kind of a risk factor for pancreatitis. Family history of any pancreatitis, family history of pancreatic cancer. Medications are important. We'll go through that in a second. Here's a basically just a table showing basically the most common causes. Stones are probably the most common. Okay, alcohol is a close second. Then you have triglycerides, drugs. They thought 6-MP, valproic acid, azathioprine. These are probably some of the most common. They didn't list diuretics here. That's another one. The thiazides are another one that we see. I think it's a classic one. There's some other stuff, ERCP-induced pancreatitis. That's obviously, you'll know that in the history, but we'll talk about that at the end. Infections, any virus. It's weird that they didn't put COVID here. So COVID was a big one back in 2020. We used to see a lot. Saw some bad pancreatitis from that was chalked up to COVID. So keep that. Tumors. Here's the scorpion bites, which you only see on a board exam, I guess. But yeah, there's some other rare stuff, esoteric stuff like autoimmune panc. But just keep that in mind that stones and alcohol are the most common ones. So again, looking at this, when labs, what are the important things at the lab? CMP. So what I'm looking for in a CMP, basically the renal function. It's a marker of, hydration status. Calcium levels, hypercalcemia is also a cause. It's a metabolic cause of pancreatitis. Triglyceride levels are another one. An EOT of greater than 150 in a setting of pancreatitis is 95% positive predictive value for being biliary pancreatitis. So just like this case, even though she had no biliary dilation, you can almost assume this is biliary pancreatitis just based on that fact alone. So again, so as a resident, when you guys are seeing these patients, the next thing we do is try to predict severity. There's all these cumbersome scores, Apache criteria, Ranson's criteria, BISAP. I think the thing to know is that some of these are, you look at admission, some of them you look at 48 hours. None have been proven to be helpful than the other. I still think it's important to think about some of these things, some of these variables that you're looking at. But at the bottom line, you got to be a clinician. Vital signs are vital. I always say it. So vital signs, there's certain labs that I really do pay attention to that are part of the Ranson's criteria. BUN and creatinine, white blood cell count, glucose. I really don't get an LDH, but if it's there, but these are some of the things on admission that I look for that'll let you know. So, a lot of times I think people make the mistake that think that pancreatitis is like 80% of cases is 2 to 3 days in the hospital. We give them IV fluids, they get better, make them NPO, they may get their gallbladder out, they stop drinking, whatever the cause is, and they go home. And everyone's happy. The hospital wins. It's a quick, inpatient, outpatient, that, encounter, and it's easy. But 20% of these patients will have severe disease. And what I mean by severe disease is like morbidity and mortality. We just had a 54-year-old that came here. I think it was like 2 weeks ago now, maybe. He came here like day 6 into his hospital stay from Riverview, and he was diabetic. I think had high blood pressure, and he came in with bad biliary pancreatitis. How bad? Intubated, CVVH, two pressors, and ultimately died. So it's a you have to keep this in the back of your mind. Not all pancreatitis, not all biliary pancreatitis, but not all pancreatitis is a 2 to 3 day hospital stay. You have to keep in mind some of these patients will go on to develop organ failure. And predictors of that are obesity and age. So just keep that in the back of your mind too. So this is a more of a radiographic thing. So this is how a classification. So, we showed on admission, on the CT scans, there's different type flavors of pancreatitis that we see radiographically. There's the acute interstitial pancreatitis, and then there's the necrotizing pancreatitis. Again, takes about 48 hours to really know whether or not on a scan, if you can rule this out or not. Sometimes it's there on admission. Sometimes it's subtle. Sometimes radiologist misses it. You can go back and look at it though. And after this, you start getting these other things, and there's terminology, and I don't want to bog you down with terms, but anytime someone has any kind of collections, a lot of times it's a pseudocyst. So keep in mind, a pseudocyst has a rind around has a rind or a of inflammatory tissue, scar tissue, fibrous tissue around it that basically surrounds fluid, and that takes about 4 weeks to really to truly develop a true pseudocyst. Maybe give or take a little bit, but usually around 4 weeks. So anything before that would be called an acute fluid collection. Now, if they have necrotizing pancreatitis, we call it an acute necrotic collection. So it's really a timing thing. Why is this important? So this patient I just explained to you a second ago, like day 12, they called me back because he had, I don't know, 100.4 fevers, and they just scanned, and he had some sort of inflammatory phlegmon starting to form. Unfortunately, at that point, there's not a whole lot that we can do as therapeutic endoscopists to help the patient. You kind of have to get him through the acute phase, through the surge, through the organ failure, through all that stuff before we can do anything. And after 4 weeks, you get what's called wall-off necrosis in these patients that have these acute necrotic collections. So timing is important. Why? Because it gives me an idea, gauge what I need to do and when I need to do it. And again, time is not arbitrary. We always, we take, every patient that, we've been these rules sometimes. Sometimes we've done stuff, we've arranged stuff in patients. I think maybe the earliest I did was 9, 10, 11 days, something like that once. And a patient that I absolutely thought needed it, and I'm based on CT, I thought had enough of a wall to do it. But these is just really just, helps me in determining when to do something and when not to do something. So again, this is just a schematic basically looking at the Ranson's criteria here. So, on admission, age, white blood cell count, and it's predictive. Again, this is not better than any of the other ones. So if you use some other criteria, that's fine. It really, again, some people criticize it because you have to wait 48 hours before you really meet, you can really truly assess. Again, I go back, I like the ones on admission. To me, they've stuck in my mind, and it can really give you a good idea. This was the Atlantic classification of how we basically clinically, risk stratify these patients. And this is probably important for ICD-9 codes and those type of peoples, but how you document a chart. So, most of the stuff that we see is the mild acute pancreatitis. If there's any transient organ failure, less than 48 hours, moderate severe acute pancreatitis, and a severe acute pancreatitis would be persistent organ failure past 48 hours. So again, back to this patient, so we have a 78-year-old biliary pancreatitis, appears uncomplicated, stable when you see them. Hospital started on fluids, MRIs ordered, and as a resident the next day, this is what you see. So initial CMP was normal. Now you have a BU and a creatinine on hospital day 2. And a lot of times when you see patients, you're picking them up, probably from the team overnight or the day before. But if you walk into this and you see this on hospital day 2, it's a harbinger of what's about to come. And that's usually something that you have to, and you still have a little bit of a window depending on time, but you're running out of time when you see this. So, when I see these patients, or if I see this in a patient that I know I'm getting consulted on, I'll like run to that patient first just to try to do something, because that's something that's, this is kind of predictive of what may happen. I think one of the worst things that you can see besides being in creatinine is hemo concentration on day 2. So if you see the hemoglobin stay the same and not fall 2 points, but if you see it stay the same or go up, going up is the worst. And I've seen this hemoglobin 15, they get a 250 bolus by somebody, and then they're forgot about in the ER, and you go in there, not even on IV fluids, and then the next day their hemoglobin's, it's higher. That's a big deal. So, so on to treatment.
Before you go to the treatment.
Yeah.
You all don't remember, but perhaps originally pancreatitis was treated with fluids, till we had the Anasaka patients lying in bed,
Yeah.
And nowadays that has gone down, but you're just pointing it out.
No, I know. So fluids are still important. I think we'll talk about fluids and how much to give, and we'll talk about the trial that does that, because I think it's important for you guys to know that.
Okay, so you're coming to the
yeah. So fluids are important. I honestly think this is probably one of the most underrated things that we give people in the hospital. IV fluids is like, I think it's better than antibiotics sometimes. I think all they need is, I mean, this goes for so many things that we do. I feel like there's a big, anyone that gets admitted to the ER, even if they go home, they're getting antibiotics for, you name it, a UTI, pneumonia, and it's like they came in for a sprained ankle. Yeah, I mean, it blows my mind. But this, fluids is probably one of the most underrated things that we give people, and especially in pancreatitis, and there is a role for it. So I do think that, crystalloids, so normal saline lactated ringers is fine. There is some thought that maybe lactated, because it's less acidic, maybe more optimal. I don't know if that's proven yet. And actually, there's a trial going called the Waterland trial that's, I think, still going on right now. So I think the verdict's out on that. But I think the answer to the board question would be crystalloids. So, saline or lactated ringers. So anyone know why I show this? Yeah, exactly. So this is a pivotal trial. So this, I think, came out, 2022, I think this came out. Yeah, 2022. Yeah. So this was a trial, and what they did is they randomized, it was almost 250 patients, and they looked at what we talked about with aggressive fluid resuscitation and moderate. So I agree. When I was resident, the way we trained, we'd put people on heart failure or intubated before we stopped fluids. And I think a lot of times we got away with it, but this trial actually looked at that, and they defined what's aggressive and what's moderate. And it's weight-based, and there's an infusion. They changed, and they looked at this, and they did 250 patients to 18 centers. I think it's Spanish trial. So, and they reassess patients, I think every 12 to 24 hours. And what they did, they had to stop the trial because more patients were going, the only thing that was really significant, more patients were going into fluid overload. And there was no difference in hospital stay in terms of length. There's no difference in outcomes. There was no difference in who got acute, nasty, complicated, severe pancreatitis and who didn't. So there's still a role for fluids, maybe just as not as we thought, but this is an important trial. This is evidence-based. So just keep this in the back of your mind. So fluids are still important. It's just maybe it's not as much as we used to. So nutrition's another big one. I wish I could. There was an article that I read as a resident back in 2007, or was a fellow, and I think it was published in the Journal of Parenteral and Enteral Nutrition. And it was an amazing study because it really broke it down to the cytokine level, and they broke it down to the Th1, Th2 response. And no one likes immunology. I think it's the most complicated subspecialty of medicine, but it's important. Everything comes down to inflammation. And remember, the GI is the biggest immune organ that we have. And these patients are already, especially the sick ones, are already in an inflammatory state. Would you fast someone? Keep in mind that the GI tract's the biggest immune organ in the body just because of the sheer surface area. You propagate that pro-inflammatory state. So fasting patients, again, this is how things change. Do they need to absolutely be in the NPO? So I'm not so sure. So I'm always asking the question, does the gut work? How bad are they? If they're having nausea and vomiting, I probably wouldn't feed them. Okay. What if they can't tolerate oral intake? What if they're intubated? So OG tube, NG tube. I don't think there's any data that suggests that post-pyloric, post-ampullary feeds are any better than the just nasogastric tube feeds if someone's intubated. So this tube looks like it's a You know, it looks like it's a jejunal feeding tube. You don't have to be that far. It can even be in the stomach. But so that's, you know, so use the gut if it works. Okay. Gone are the days of pancreatic rest, I think. You know, so there's actually some recommendations now, like, you know, starting them on a low-fat diet, like not going from clears to fulls to what you see. You can even start them on a low-fat diet, and there's evidence for that too. So I get in arguments all the time with our biliary surgeons about this because I feel like they fast everyone forever, and it's like for bad pancreatitis. And it's like the pancreatitis was 4 weeks ago. You know, like fast them now is not going to make a difference. Dust is just settling from the bad inflammation. So we go back and forth, back and forth. It's very academic. I love giving the surgeons a hard time. Um, but yeah, so just you don't have to fast these people. Now, again, if someone has bad pancreatitis and say they have an ileus, their abdomen's distended, that type of thing, yeah, those are patients that I'd consider, you know, alternative, TPN or something like that. But I try to avoid it at all costs if possible. Most of the ICU doctors are pretty good about that too.
Do you believe that the patient has some say in it? Because I have seen over the years that most patients who are sick, they tell you if they want or not.
Yeah.
You know, and if
Yeah.
they say, you know, oh, I think I can have soup or God knows what,
Yeah.
you know,
I
always follow that.
I think that's a good, yeah, I do that too sometimes. I'll ask patients, I'll ask them, that's kind of a question how sick they are. I ask them, how hungry are you hungry?
Yeah.
You know, and that's an indirect way of me figuring out how they feel,
Exactly.
So but yeah, if the gut works, again, examine their belly's soft, they're passing gas. Start, you don't have to if you're in between. You can always start them on clears, but you really don't have to do that. So antibiotics is another thing that you see a lot in the hospital with pancreatitis. I think there's role for certain types of pancreatitis. Keep in mind these patients with bad pancreatitis, the necrotizing pancreatitis, these are the ones where they're always on antibiotics, but the question is, do they need to be? And I'm not so sure they do. So most necrosis is sterile, and most necrosis takes about, if it gets infected, and not all of it does, usually somewhere between day 10 and day 14. So there's other sources of infection, ventilator-associated pneumonia if they're tubed, line sepsis if they have central lines, this type of thing, bacteremia. But I think the downside of antibiotics is that you select out and you're basically creating resistance, giving the fungus a chance to win when we do this. And most people put them on. I'm just not sure it's evidence-based, or you have to. This was a trial, I think also 2022, published in Lancet, looked at procalcitonin, and they looked at this, and they found a 20% reduction when they followed just procalcitonin levels at various times and time periods. So, I don't know if we're there. I don't use procalcitonin, but it's interesting. So this is, the Brits are a little bit different than us, but certainly may be onto something with this approach. Biliary pancreatitis, this is kind of a subset of pancreatitis. You see this a lot. Again, stones are probably the most common source of pancreatitis. So gallstone pancreatitis, we see this a lot. And one thing I always try to figure out is their cholangitis present. Sometimes it's hard to know that. These patients are, especially if they have a bad attack of pancreatitis, a lot of patients with pancreatitis will sit with the temperature right around 100.4. They just sit there. That's like classic for just acute bad pancreatitis. But I always like to know, is there a stone present? And if there is, when is the time to go in and get it? I don't know there's a right or wrong answer to this. A lot of our guidelines have come out recently and suggest against ERCP and biliary pancreatitis. Why? Because it really doesn't do anything in a long-term form, doing it on an urgent basis. I kind of use my clinical judgment when the pancreatitis is resolved, they're better, and then do it. That may be a day, 2 days, just depends. Some people bounce back within 24 hours, even if their labs are still elevated to lipase. But if they look great, then maybe I'll do it if there's a stone there. But obviously, if you do think cholangitis is there, these are the patients. This is a subset of patients I think probably should be on antibiotics. It's people with biliary pancreatitis, at least when they come in case there is a stone present. But this goes back to etiology, figuring this out. So again, these are patients that you want to know. Is this biliary? There's different ways to find stones. It's a whole separate talk. We do MRIs and endoscopic ultrasounds. There's different ways we can go and figure that out. This is an EUS image here. You can see a stone in the duct here with the shadowing. I do this procedure just about hand in hand with every ERCP, especially for stones, just because sometimes the stone's not even there on the MRI that you can see here. Sometimes they pass it somewhere between the MRI being done and when I do the procedure. So So EUS is nice because there's no risk of pancreatitis from that procedure. So when we do ERCP, this is a schematic. I'm sure you guys are all familiar with this. We don't really know how stones cause pancreatitis. It's thought to be a plumbing issue. In reality, the junction between the bile duct and pancreatic duct is not what it shows in the schematic here. In reality, it's literally right here, right at the level of the duodenal wall. So, but it's thought to be ductal hypertension. And we'll go in and we'll take a stone out. And this is what it looks like here. You can see the stone being exposed after the cutting the sphincter here. You can see this impression, this bulge of the ampulla here. That's probably just stone just sitting behind the ready to be delivered. So this is another one. Sometimes you got to push back on the surgeons here, and I this is something you guys have to do too. I try to do it when I can, and I'll tell you because I've been burned in the past. So, you know, you have to keep in mind, and you know, the surgeons here, they're more of a lot of them are hospitalist based, so they don't necessarily have an outpatient practice. But if someone comes to the hospital with biliary pancreatitis, they should get their gallbladder out before they leave.
Yeah.
They really should.
Thank you.
And why? Because there's less readmissions. This is their data, less readmissions, less biliary complications, and there's no change in operative complications. You'll see so much stuff done in this hospital that I would ask you guys, just, I'm not sure. So you'll see stuff like, well, I got to wait for the enzymes to go down. There's no evidence that you have to do that. Okay. Like the LFTs, I took the stone out, the stone's gone. You know, we used to have surgeons here that we would do, you know, ERCP, and 5 hours later to take them straight for gallbladder. I mean, if stone's gone, yeah, sure, and do it. So that can be done, but you also see stuff sometimes, and sometimes it's because its patients are a little bit more complex. And you know, maybe there's a reason, maybe there's some biases there, but you know, keep in mind that you know the data suggests that these patients should get it. And you know, classic case that I see sometimes, and it's because I'm not involved. Patients comes in, get submitted to, you know, the women's center. They're week 8 with biliary pancreatitis. They get better, the numbers are better, and they'll say, oh, you know, the MRI was negative, go home, you know, get your gallbladder out. That is the absolute worst thing, because guess what? They show up when they're 32 weeks pregnant with, and now they need an ERCP. Now you have 2 people, and third trimester is a lot harder than second trimester. And, you know, 32 weeks, lungs may or may not be matured. So there's just, and I've had this, I've been burned with these cases before. I've seen it. It's a lot more different doing an ERCP in a gravid, a patient during the third trimester than it is first, second trimester. So, again, so push these patients, you know, you got to push for these patients. They need their gallbladder out because they will get complications if they don't. So, and it's cost effective. So, that's always important. So,
what is the best argument for us if you have a surgeon who says,
Yeah,
you know how we follow up as an outpatient in a few days?
yeah. So the problem with so a lot of them don't have outpatients though. So keep this in mind. So when a patient, if they don't have an outpatient practice, what happens is, what's the reality of that? So patient has to go find a surgeon, find an insurance plan, get him. That all takes time. That all takes weeks. That's even if you know somebody. It takes time. So I think the thing is, if they have biliary pancreatitis, and again, there's one caveat. I think the caveat is if someone has the nasty stuff in the ICU that's going to require necrosectomy, drainage, and all that stuff. Yeah, those patients, that's back burner stuff. That stuff could probably be pushed back, because honestly, there's not a lot of pancreas left to get to worry about, because it's all dead anyway. So those patients, I mean, maybe, and probably, but you know, for most part, you know, patients that have acute biliary pancreatitis, you should really think long and hard, and it should be a good reason and documented to cover yourself why it's not done in the hospital. Again, there's a lot of pushback for different biases and stuff. I've explained a few of them and stuff. Sometimes I try to figure it out and I can't. But it's up to us. And I do my best sometimes to push them. And sometimes it depends which surgeon's on call. That's just the reality. That's what we work. But so back to this patient that came in with 78 biliary pancreatitis. Again, hospital 2, we knew that she may be in trouble. So now she's 12 days later. She's on tube feeds. White count's 15. Temperature's 100.4. MRI is negative for stones. Her LFT is normalized, but she's just not doing well. And so this is what her image looks like. So what do you guys think about that? So what would you call this? So we're day 12. What would you call this? What's the correct term?
Very pancreatic fluid collection.
Yeah, I mean, so yeah, acute collection, but it's necrotic. How do I know it's necrotic? Look, you got enhancing tail, you have enhancing head, and you have a big hole right in between. Okay. So this is contrast. There's contrast here. Kidneys light up, liver lights up. Don't see the spleen here, but you can tell this enhances, where all this stuff doesn't. And then you start to get this collection out here. You start to, what I mean by start to, you start to see like a little, kind of a well-defined rim to it. You see that? So I cheated. What's the next step? This is the next step right there. Don't do anything. 3 square meals, close the door, keep them away from doctors and procedures and needles and stuff. Leave them alone. So they need time. So again, hospital day 12. So the collections, there's not enough to do. Everyone's freaking out because temperature's 100.4, they're in a hospital. You got the case managers after you guys when you discharge this patient. I wish there was a way to make this time speed up. A lot of times you can't. You just gotta let the body do what it does. And so patient gets better, goes home 3 weeks later, now comes in with fever and abdominal pain. So now we're 3 weeks plus 12 days, so right about 4 weeks, and now you have this scan. And this is what we love to see as gastroenterologists because now we can do something. So what you see is you see this big collection. What you don't see, or what's getting squished right here, is a little part of the stomach right here. That's the stomach that's being completely compressed. Okay. So this is the hepatic artery, celiac artery, splenic artery. Okay, but you see you got this nice walled off area. Now, again, in this patient, if the radiologist says that's a pseudocyst, it's not. I'm telling you, it's not. So, I mean, it looks very homogeneous on a CT scan, but I promise you there's going to be dead tissue. And the reason why it's important, pseudocyst is just fluid. This is very easy to treat and put a stent in, it drains, it's out by the end of the procedure. But when there's necrotic pancreas and walled off necrosis like this, which is how I would describe this, this would be walled off necrosis. It's a lot more of a cumbersome procedure. It's not just one procedure. Usually it's multiple procedures. And what do I mean by that? So we see what we do called endoscopic necrosectomy. And we do this. I think next time I do this, I'll try to get a video. I got to get a video of us doing this. But so basically we put a stent in, we basically perforate the stomach wall directly into this collection. So we put a hole, and that hole is usually around 15 millimeters. The diameter of the stent's about 15 millimeters. And we're banking that that collection is stuck to the stomach and that there's a rind behind it because you have a hole essentially in the stomach, just a free hole. And what do? It's exactly what we do. We put the camera through this stent, as you can see in the x-ray, and go straight through it and basically debride this stuff. And sometimes it works great. Sometimes it's labor intensive. You got to roll up your sleeves and kind of just, get down and dirty, and it takes multiple procedures. But that's kind of what we do for these patients.
Is it a suctioning system, which is sucking out the pancreas?
It's not sucking it. I wish it was that easy. No, it's so we go in and like here, you can see in this schematic, they're using a snare here. So we use snares, you use all kinds. Sometimes we use a macerator. It's a catheter that has like a blade on it that you suck in, and it sucks it in and cuts it. And it's just, so there's certain things that we can do. Unfortunately, there's not a lot of devices that we have. So it's kind of an area of development. I think that a lot of people are looking into, a lot of the device companies and stuff, because we're kind of just stuck. A lot of it's just, a lot of these patients will get better. Sometimes, there's some argument whether or not you do necrosectomy. Sometimes just putting in the stent, taking out, draining the fluid, especially if there's any pus, that will help. But ultimately, trying to get all this necrotic tissue out, I think, is in the patient's interest. That's kind of my approach. I know Dr. Khan's the same way. I think he feels the same way I do about this. We try to kind of more aggressive and try to get on with it and get what we can out.
The wall.
The wall. This is basically, this wall is a security blanket for us. So what happens with time is the wall will basically, when we're done, the wall will collapse all the way around the stent. And what happens is at the very end, you go put the scope in the stent, and you hit there's a white wall right there. Not a perforation, it's just a wall. So it's a cool thing. The body just heals right up against it. So when we remove the stent, it's not like there's a big hole in the stomach. No, you got this wall that's healed up right behind it. So, go ahead. Yeah, sorry. No, I wouldn't. That's blasphemy in our world. Yeah. Do you know why? It's a good question now. This is what gets done in all the other hospitals. The problem with the PERC, what do you think the problem with the PERC drain is right here? It's just this. I don't expect you to know this. This is like, you just really have to think. You have to think like how we think is like 4 steps ahead. What's the problem? What happens when you put a PERC drain in? Very easy to do. The radiologist, they're like, oh, sure, I'll put a drain in there. Drain all the fluid out. And then what happens? Huh? Easy to take. No, well, not, yes. Fistula. So what happens is, so that catheter they put in, not only it takes away my nice big fat balloon here to do this procedure, it leaves all the solid stuff. And then what happens is, because when we put this in, sometimes it's hard to do if there's not a lot of fluid. This stent won't open up if there's just a lot of dead tissue. So sometimes we have to wait for fluid, or we have to even put fluid in there. But if you put in a perk drain with just a bunch of little side holes in it, they're going to take the fluid out. And then what happens is that disconnected gland that I showed you before, that enhancing tail or whatever, or sometimes even at the body, wherever there's probably a hole on both sides, it'll find the path of least resistance. And if they have a drain in for a long time, you go to pull a drain out, they'll just constantly leak and you get a fistula. So there are certain circumstances where we do, and those are the ones that we can't get to. What are those? The pericolonic collections. So sometimes you'll get these big collections and they'll sprout out and they'll go down into the colon, near the colon, in the recesses, all the way down, all the way down, in the pelvis. So some of those we can't reach. We'll drain up here, and we'll also drain them from the sides. There was one, I saw them in the clinic. There's one case we had back in 2016 that we did where we actually had to do, the surgeons had to do, we did all the stuff, put in a drain, did necrosectomy, put in bilateral drains in both of his colonic or pericolonic collections. And ultimately the surgeons used the drains and did video-assisted retroperitoneal debridement. So that's probably the only case I've seen done at this hospital. And that was about 10 years ago. So, but those are things that you can do if push comes to shove.
And the perforation in the stomach is just healing by itself, even if there's inflamed tissue under there.
The inflamed tissue actually helps keep it stuck up against this, so it keeps the
Almost like
collection from dehiscing.
Okay.
So you want the inflammation, you want it there. And again, that's one of the reasons why we wait 4 weeks too.
Excellent.
You want it nice and stuck. These stents that we put in here, they have a flange here, like a mushroom.
Right.
That kind of helps keep they're called lumen opposing stents because they keep things tight against each other.
Perfect. Thank you.
Yeah.
There is a video on the YouTube for 3 minutes if you want to play that.
Oh, it's okay. Yeah, we'll create it. We'll get our own one. We'll give a real video. So
Like a better visualize.
yeah, exactly. Yeah. So now you have the same patient a week later, comes with hemoglobin 6, hypertension, may have had some black stool. What do you think's going on? Huh? Oh, sure. Okay. Yeah. Okay. Yeah. Black stool, GI bleeding, but tie it all together. Be an intern. It's like tie it all together. Like what's
Hemoglobin.
One of the arteries
yeah. So what's that called? You're right. Huh? GDA is one site. That's not the only site, but what's the term? What's the name for that process? There we go. What's the name of this thing with a big star on it that's got contrast in it? Here's a splenic artery. What's right next? Huh? Yeah. Pseudoaneurysm, but so pseudoaneurysm, yeah. So you can see the collection here, but you can see this big thing here. So how do we treat that? I give you a hint. I don't treat it. I wish I could. Embolization. So in this case, you would take out this either the splenic artery and or the aneurysm itself. That's a massive aneurysm. So sites, you're right. GDA is one of them. So that's more along the head. You would see hepatic artery is another one. Splenic, especially in the body and tail. You can see how close the splenic artery is. So always keep that in mind as someone comes in, that has this kind of history, bad pancreatitis, got debrided, and now they're bleeding, so don't blame it on my stent, but always be mindful of a pseudoaneurysm.
I guess I have a question because of the Rhine where you had all the arterial supply and then there was the necrosis. Can the necrosis go into the arteries and cause the bleeding?
Yeah, I mean, I think that's part of how this formed. That's why they're called pseudoaneurysm. I think that's the pathophysiology of development of a pseudoaneurysm is basically that inflammation and that process basically eroding into the wall, So sometimes you can get venous bleeding too. Sometimes these patients, if it's a process, sometimes their portal veins out and they have collaterals or splenic veins gone a lot of times after this, so they get collaterals. And sometimes, rarely you take out the source, which is just, take out the inflow, which is the artery, and take out the splenic artery. So sometimes you have to do that too. But just, keep in mind this picture to always be worried about a pseudoaneurysm. So the test of choice would be a CTA. That'd be the test of choice. So another case, we had this couple of weeks ago, kind of an interesting case. 33-year-old, known hypertriglyceridemia, these guys own 2 or 3 medicines for it, medicines I've never heard of. And he went into Zephyr Hills, I think, end of June, pancreatitis. And basically, he had a long, I said, well, let's say he was there for like in and out of the hospital for a month there several times, kind of just wasn't getting better. And they ended up just transferring here. Now, patient never had organ failure. But it just wasn't getting better. 33-year-old guy, healthy otherwise, just not getting better. And not getting better NOS, that's what I'd say. So they kind of threw their hands up here and they do what they normally do, transferred here for surgery. Okay. And then we have to kind of fix the problem or figure out what the problem is. So I think knowing the details, going through when I see these patients, I try to figure out how bad it goes back to the history. Like, and you get sometimes you get a little chart diving and look at their old films, but try to figure out where they started and where they've come from and what happened. So, the fact that he never was in the ICU, never had organ failure, I don't think he had necrotizing pancreatitis, but let's look at a CT and figure it out ourselves. So let's see here. Do you know how to, maybe it's because the laser's on? Is that why it's, oh, hold on. Oh, sorry. Yeah, I'm just trying to see where that little stay thing is. Yeah, there we go. Yeah. So you can see here. So look, the pancreas enhances. Here's the spleen. Here's the pancreas. And I'm putting the arrow here. Can you see that black arrow? Yeah, that right here. That's the pancreatic duct. Watch what happens as you go down. Boom. Turns into this collection here. You see that?
Oh, yeah.
Right there. And then you start getting all this. And then that communicates with this. See all this over here? So, let's see if we can go back here. Oops. Okay. So, what do you think the problem is here? So again, the guy never had organ failure. His pancreas enhances, yet he's got this collection around the duodenal head. Showed you that pancreatic duct. We'll look at it maybe one more time here if I can. Should do that. Oh, you gotta get rid of the mouse. Yeah. So again, this all enhances. Here's the duct, here's the duct, here's the duct. Again, this is a special circumstance. There's the duct there. As we come down the head, you get this literally a blowout right there. Not disconnected. Disconnected, you just see when there's no communication between head and there's usually a necrotizing pancreatitis. So another clue to this problem is what if he had a bunch of ascites? Breathing ascites is coming from
Duct leak.
Duct leak. Yeah. So let's see. How do I see? Oh, here we go. So how do we treat a duct leak? We do an ERCP. So this was a very challenging case. So you can see this is air here in the stomach. This is my scope. This is not even an ERCP scope. This is a regular scope. And you can see the air here. And the air basically stops right here. And you get a little bit of squiggly air here. Why? The duodenum was being completely compressed. That's why this guy was not getting better. He couldn't eat. Nausea, vomiting was a big thing. He's got a duodenal obstruction. So this is me with a wire using a regular scope. And fortunately, we were able to find the ampulla. And I wanted to see if he had a duct leak. I was almost certain that he did. This is contrast that's spilling back in the duodenum. But as I get contrast in here, what you see is now you start to see this thing. This is contrast outside the duodenum. And there's a leak right where right here, there's a leak. I didn't record it. I wish I would have recorded it. You maybe see it better. But this is all fluid starting to come down and track along around that duodenum that we saw. And how do we treat that? Well, we put in a stent. So, imagine there was a leak right here. We put in a stent. The stent basically helps just redirect fluid back down to the duodenum and can serve as a bridge too. So that's what we did here. We ended up putting in a stent with an EGD scope, which was kind of a miracle. But I'm glad because I think that's what he needed, and that's what he needed all along. So pancreatic duct leak, again, goes back to the history. The guy never had organ failure, never had necrotizing pancreatitis. So we knew that's probably what the issue is. So wrapping up here. So this is something that we'll see post-ERCP pancreatitis. How do we define it? We don't define it by someone that does a lipase the next day and then you go to see them and they're eating food, ask them if they can be discharged. That's not post-ERCP pancreatitis. So it's the same way, the same definition. So there's all kinds of reasons patients can have post-procedural pain after an ERCP. Pancreatitis is the most common. And how often does it occur? This was, I think, 2023 in GIE. They looked at 145 randomized controlled trials, and they found about 10% of patients. So I usually quote patients about 5 to 10%. And there's certain things that probably are above what you need to worry about, some procedural related things that we do. But, you know, there's certain things that who gets pancreatitis, and this is probably the most important thing is selecting the right patient for ERCP. And what you guys should really understand here is this second bullet right here. It says ERCP should be a near exclusively therapeutic procedure. Do you guys know what that means? So,
It should be the only one.
no, well, what they mean by that is you shouldn't be going there and putting in dye and be like, there's no stone, there's no stricture, there's no mass, there's no leak, there's no, you know, have a good idea. So you don't want to go, you want to go in there, if you're going to do ERCP and put the patient through a 10% risk of pancreatitis, you want to do it for a reason. You know, nowadays with endoscopic ultrasound, MRIs, and all the other things that we do, you know, you shouldn't be going in there and just putting dye in. There's a few select cases, you know, where we don't do anything. Bioleaks that have a bioleak that maybe the liver, there's a transected duct way up in the liver that we can't get to. Well, it's still an important procedure. You had to do a diagnostic procedure to prove it. But large, so one of the things that we can do is, you know, that helps, it's the patients that don't need the procedure, those are the ones that get pancreatitis. That is the reality, and that's evidence-based. I mean, it really is. So patients that getting it for like weak indications, week out, you know, those are the patients that unfortunately will get, you know, is a risk factor for pancreatitis. Other ones too, so if they have patient-related factors, so patients that, you know, have a previous history of posterior pancreatitis, sphincter of Oddi, that's kind of like, you know, ampullary stenosis. This is a big one. It's a real thing if they meet all the criteria. A female, young female, these are all risk factors. And then, you know, some of the procedure related stuff like hard cannulation, stuff like this. But there's certain things that we do, that we try to do, you know, intraprocedurally that you guys should probably be aware of, because you probably will see this when you share our reports. Rectal NSAIDs is a big one. So there's two of them, indomethacin and diclofenac. These are two that I think we use indomethacin here exclusively. And that's 100 milligrams. That's evidence-based. I think since there's a trial that came out in 2012 that looked at this. Stents we've been putting in way before 2012. There was a study that basically was published in the Lancet in 2024 that actually looked, hey, what about doing both? And actually, was evidence for doing both. I do this. I do this in practice and was doing this even before this trial. I'm a big believer in pancreatic stents, and but stents plus indomethacin alone prevented pancreatitis 30%, you know, in comparison to just rectal NSAIDs. So, and there's a few cases of severe posterior pancreatitis. So this study, I think 20 studies. I can't remember exactly how many patients. I'm not 20, it was 20 centers, high volume centers. So really it was a good study because you could really took a nice sampling of a lot of endoscopists. So I think these are really good numbers to look at. So wrapping up here. So I love this because it's the things to avoid. So again, this goes back to definition. Don't make the diagnosis unless you have two of these three. Don't let the ER like fool you guys. Oh, I got a patient with pancreatitis. Sure, you admit him there, and it's like, well, dang, it's a non-ST elevation in mine. So, oh, there we go. Yeah. Perfect. And I can tell you the second one is something that patients get really upset at. And you see this when they get transferred from other hospitals. You know, you're like the fifth person to ask them, you drinking alcohol? So I got to be really careful the way I ask it because they take it out on me. Everyone thinks I'm alcoholic when I go to their hospital. I'm like, that's just because they're just trying to make their job easy and not, you know, and not figure out what's really going wrong with you. So don't fall into that trap. Don't forget about the rare causes of pancreatitis, scorpion bites. I'm joking. Triglycerides, malignancy. There's some genetic stuff. We really can't do anything about, but autoimmune's a big one. Yeah, that causes all kinds of weird stuff. And again, we talk about the complicated systems, or do not overly complicated systems to estimate prognosis. We talk about some of those. Again, use your clinical judgment. SIRS, vital signs, heart rate, respiratory rate, blood pressure. Vital signs are vital. BU and creatinine, hematocrit. I love these. We talked about fluid resuscitation support and just don't overdo it. We talked about the waterfall trial. And do not use TPN. Maybe we should give this lecture to the surgeons so they know that. Use enteral nutrition, whether it's tube feeds, whenever possible. We talked about ESCP, prophylactic antibiotics. And the last one, don't intervene too early in infected pancreatic necrosis because it doesn't change outcomes. So let's see here. How do we use
How do we
it?
get-
Yeah, here we go. Yeah. Oops. Should be the second to last slide. Yeah. So in summary, so just remember, it's important to, again, come to a correct diagnosis, because if you do, that's going to help you, triage these patients appropriately, then figure out what the etiology is, try to predict severity, again, using, your bedside clinical skills, and be mindful of necrotizing pancreatitis because it's a real entity with serious morbidity and mortality. And these patients have a very long, different, prolonged hospital course, even a course afterwards too. So if you have any questions, let me know. Thanks for your time. Oh, yeah.
As you know, with the increased use of GLP drugs,
Yeah.
at least 4 cases of rethinking,
Yeah.
it's idiopathic or GLP-induced pancreatitis.
Yeah.
2 months ago, this lady told me, "Hey, do I need to stop Manjaro?" Are you sure? Is it from Manjaro? I said, based on the FDA data, 1 in 500 cases, when they submitted the data,
Yeah.
There is pancreatitis drug trials. So I said, could be possible because I looked everything is negative, no stones, no triglycerides, no alcohol use. We even did IgG4 that came back negative. She has been here for a very long time. Result. I said you should not use it. Doctor, one of the GA doctors is also on the service.
Yes.
And then she asked me, can I use Wegovy? I know Manjaro is GLP-1 and GIP. I don't know which one is this. I said, I don't know. Maybe you can try. But that's what based on what is your experience.
You know more about it than I do in terms of, I don't think there's a right or wrong answer to that. I don't think there's any evidence-based answer to that question. It's a good question. I think it's probably what's being done. And again, these idiosyncratic reactions and, it's the diagnosis of exclusion, proving one thing's the other. I think looking into the temporal relationship would be helpful in a case like this, like how long they've been on it, is there a time? But you're right, these drugs have been implicated in this. So yeah, my wife's an internist. She tells me this all the time. Yeah.
So you can.
Yeah.
So I read that pancreatitis, there is a role of pancreatic ductal hypertension in like most cases of pancreatitis, even if they're not associated with stones. And I've also read some studies showing that early ductal stenting improves outcomes, reduces hospitalization, and can lead to like early treating. So in your opinion, is there a role for that in any case of that?
Well, again, a lot of times we don't know. With pancreatitis, we know what happens in terms of the pathophysiology level, but what causes it? What's the actual cause? Is it pancreatic ductal hypertension? Is it, some sort of noxious injury? A lot of times we just don't know. So in terms of stenting, I don't think there's a role for putting in stents in patients. So, we put in stents to prevent pancreatitis, but in terms of treating patients like the patient like on a GLP-1, there's not a role for putting in a stent for that. So just when it comes to ductal hypertension and stuff, just to give you kind of like devil's advocate here, I've seen so many patients that have massive stones in their pancreatic duct with a massively dilated duct behind it that have 0 symptoms. 0. Okay. I can't make them any better than 0 symptoms in terms of going in and taking out stones and putting in stents. So, so keep that in mind. So there's ductal hypertension there, but why? Because the duct's dilated behind it. But these patients are asymptomatic. So so I hope that answers that question. Again, we put in PD stents a lot of times just to help prevent pancreatitis. There's also some old, data with, looking at patients with chronic pancreatitis and what we do endoscopically and stuff, where some of the endoscopic stuff, whether it's, stent placement and this type of stuff, at the end of the day, it doesn't change a lot of things. This is more for chronic pancreatitis that I'm talking about, not necessarily acute, but for chronic pancreatitis. So, duct leak, pancreatic ascites. That's a big one. So, yeah, it's a good question though.
What are the criteria for biotics? Because most of them are sepsis.
Yeah. Well, a lot of them, I went to sepsis. Well, SIRS maybe, right? So when I think of sepsis, I think of bacteremia and stuff like that. So I think, most patients, on admission, the ones that I would really that I think is probably evidence-based is biliary pancreatitis because you're worried about a stone. You're not treating the pancreatitis. You don't want another problem, cholangitis. If they have a stone, they're obstructing their bile duct and their liver function, their bilirubin's 3. Those are the ones that probably should be on antibiotics. Even necrotizing pancreatitis. By the time I get to them, they're nice, they're sick. Everyone's got them on antibiotics, antifungals. It's not evidence-based. It's really not. So when I talk to ID people about this all the time, and that's kind of my thoughts with it.
Gastric outlet obstruction and invitation to drain like a acute peripancreatic fluid collection.
It
So
could be. I mean, it could be. I mean, so yeah, symptomatic collection, and if it's less than 4 weeks, and you think that their stomach's blocked, that may be a reason that push comes to shove to do it before the 4 weeks for sure. So we've done that before, and they use that as an excuse. Like, hey, I think a lot of it depends on how it looks on the scan too. But if they're symptomatic and we think there's something that can be drained, sometimes they're not. Sometimes it's just a lot of these patients with bad pancreatitis, especially in the head, the body, and the whole collection is, the duodenum gets out. Those are tough patients. So I think those patients have a very difficult, path. So, but yeah. Yeah.
Thank you.
Yeah.
Thank
Oh, this is I think they're putting in there's a needle. Yeah, it looks like in a color. I don't know. It's not my video, so I don't
It's
know.
not yours.
Yeah. So you can see the stuff underneath that needle tip is all junk and debris. And here they're putting in, I guess, a wire. You don't have to do this, but that's what they're doing. You're using a tome. Yeah, I don't know what this video is. No one uses a tome.
That's an old one.
Yeah.
That's an old one.
Yeah. Yeah. The device that we use now has a built-in tome on it. So this is the old school way we used to drain them with wires and putting